Good afternoon, everybody, and welcome to the EUFOREA discussion on the nasal turbinate as a therapeutic target in rhinitis. I'm Glenis Scadding from the Royal National Throat, Nose and Ear Hospital in London, and it's very interesting that I'm chairing this discussion because I am not a surgeon. I am a nasal physician. But we're going to hear about two techniques this afternoon for possibly affecting the inferior turbinate, one of which is surgical and one of which is somewhere between surgery and medicine. And I'd like to introduce our two speakers first of all. Actually, I'd like to ask them to introduce themselves. Anders, please introduce yourself.
Thank you. I'm Anders Weilandt. I'm the CEO of Chordate since a few months, I might add. But prior to that, 35 years in medtech industry internationally.
Fine. And Agnieszka?
I'm Agnieszka Strzembosz. I am ENT surgeon and I am International Medical Affairs Director, Medtronic ENT.
And then please could our panel introduce themselves, Thijs?
Yeah, my name is Thijs Teling, although I have several positions in healthcare industry, but I'm here as a patient.
I'm Wytske Fokkens. I'm a professor of ENT in Amsterdam.
I'm Emmanuel Prokopakis. I'm a professor in ENT in Crete, Greece.
I'm a patient. My name is Karin Knapen. I'm a patient from Professor Peter Hellings.
Klaus Bachert, ENT in Ghent and Stockholm.
I'm Peter Hellings. I'm ENT in University Hospitals Leuven.
Thank you all very much. I think we will start with the first presentation, please, Anders.
Thank you very much, guys. I'm going to describe a relatively, or if not novel, technology to treat non-allergic rhinitis. And I'm going to keep this on a more technical level, as this method is quite unknown to most people. But I would like to pose 3 bullet points, basically. First of all, that we are aiming to fill the gap therapeutically between basically sprays and surgery, just to put it simple. I'm going to try to demonstrate how easy and simple this procedure is. It's actually prone for more or less primary care level. It could actually also be performed by a nurse after clearance by a doctor. And also, finally, touch on the long-lasting effects that we've seen for majority of patients. So if we then start by just the positioning or the segment that we are looking for is to place this non-surgical, non-pharmaceutical, long-lasting symptom reduction technology right between the options of sprays of various kinds and surgery of various kinds. We believe, and we have a lot of witnesses from the clinical world, that there is a big gap, and that's what we're aiming for. The easy and safe procedure here is 10 plus 10 minutes, 10 minutes in each nostril where you place this catheter and the machine that would cause this catheter balloon that we are going to take a look at soon to vibrate for those 10 minutes where you change over. And we also recommend that this treatment is repeated within 30 days for a second time. The evidence we have shows that we have a long-lasting effect, at least up to 6 months. But we have physical reports from the real life that this can last up to a year or even longer for some patients. It is reported to be without any adverse effects at all in any of the safety studies. And the only effect during the study is increased lacrimation, some intense sneezing, and in my case, relatively funny sneezing. And also a numb lip after the treatment that lasts for about an hour. That's about the effects that we see from it. So how does it really work? I have here a short clip that basically go through how this is supposed to be placed, and also what not to do. So the balloon needs to be emptied of air and then add some inert lubricant to facilitate insertion in the nose cavity. And then try to find the patient and the nose of the patient, and then place the catheter. The inner catheter here is very, very soft. So to place it on the floor of the nasal cavity and not, as shown here, anywhere else. This is basically the complexity of the whole procedure, just to place it right. The other thing is to press the on button on the machine, and the machine does the rest. And it also tells you when to change to the other nostril. So that means that it can be easily performed by a trained nurse. Finally, a little bit of what could be the function of this mechanism, and the notion that this is seen as something that modulates the automatic nervous system. And if we believe in this description of the pathogenesis of the nasal congestion complex, then of course that when we see from a published study from this summer that we have a profound effect on heart rate variability, that more or less binary is lowered during the treatment and then goes up again, then we might draw the conclusion that this actually influenced the automatic nervous system long term. And if that then is believed, then we can start to explain the long-lasting effect. Otherwise, this could be seen as just a massage of the mucosa in the nose. But as you can clearly see here, the study group and also, in this case, the third group have long-lasting effects over 6 months. 42% of the study subjects in this study show an effect that was significant after the first treatment. If another second treatment was added, that went up to 55%. So about half, and this is actually reflected in the real-life situation also. Clearly a matter of selection of patients. That if we better learn how to recruit patients for this treatment, of course, this result might be improved. So to sum it up, we believe that this is so easy and could be made so available to patients, not having to deal with special clinics, that this actually could fill an important gap in the therapeutic arena. Easy and safe, as demonstrated, and also that we have a long-lasting effect. And this has been in clinical practice in Stockholm for about 5 years, with quite a few patients actually treated that repeatedly come back. So it seems like this actually has a place. Thank you very much.
Thank you. Can I ask one question? How much would it cost for, say, 2 treatments to reduce symptoms for 6 months?
So of course, as always, it's a matter of reimbursement, right? But I can just draw one example from our own clinic. We are a registered clinic in Stockholm, at our office basically, and we recruit patients via Facebook to come in, and they pay out of pocket, which is quite unusual for Swedes to do for healthcare, and they pay per treatment approximately 90-95 euros.
For 2 treatments?
For one.
For one.
And they are very happy with it. Yeah.
So a couple of €100 for 2 treatments for 6 months benefit.
Yes.
Thank you. I think we'll go on now, and we'll have the second presentation from Agnieszka, who is talking about a much more common procedure, which is surgery to the inferior turbinate. Please tell us your story.
Thank you very much. Everyone who experienced difficulties in breathing through the nose knows how it affects the quality of life. And when it is related to the inferior turbinate, we can treat these patients surgically. And the powered inferior turbinoplasty, sometimes also called the microdebrider-assisted turbinoplasty, is a minimally invasive surgical technique. What does it mean? It means that it addresses the cause of the problem with the minimal risk of the complications, and also not compromising the function of the organ that is treated. The powered turbinoplasty can be performed both under local and the general anesthesia, and we have 2 types of blades, 2 millimeters and then a little bit bigger, 2.9 in diameter, and they have the elevator, which is patented, and this elevator allows to create the submucosal pocket without compromising the mucosa, because it creates the insertion into the inferior turbinate. And it can be rotated in 360 degrees, and the surgeon can work with different speed of oscillation from 60 to 3,000 rates per minute. So what is the philosophy of this surgical technique? When we have to deal with the turbinate hypertrophy, which is not responsive to the medical therapy and is manifested by the nasal obstruction, we consider this type of the surgical intervention, which is actually pretty simple in terms of the goal. And the goal is to achieve the volumetric reduction of the submucosal vascular stroma tissue with the preservation of the overlying respiratory epithelium. So the blade is inserted into the inferior turbinate at the front and the anterior lobe, submucosally, under mucosa, not under the periosteum. And when we create this pocket with the sweeping mode, as you see on the image, we create this pocket. And we can work from anterior to posterior and to decide precisely how much of the tissue we want to remove. And because we don't want to penetrate the mucosa, we preserve its functionality and minimize the risk of the complications. So what we know today about the clinical outcome? There are a number of ways to evaluate the clinical outcome, some the objective measurements and some subjectives. And in this presentation, we have selected the subjective one, which is actually the simple question to the patient, how do you feel? And we call it visual analog score. And when you look at these two graphs, which were taken from the publications, actually they're not so young. They were published 10 years ago. And they show the long-term result, very positive for the patients over the 3 years. And the reduction of the problem was dramatically low and persists in 82% of the patients. There's also the study published in 2008 by Glenis and his group, where they observed for 10 years the patients, and they noticed that 91% of the patients were free from the symptoms. There are a number of studies confirming that there were no major post-op complications such as the bleeding, crusting, or atrophic rhinitis, both in adults and in children. And if you look at this image, this is the pre-op image of the hypertrophic turbinate and deviated nasal septum, and this is the image 7 days, doesn't work. After the surgery, when you see that the distance between the inferior turbinate and the septum is large enough so we can see the nasopharynx. And the long-term effect is really, really high comparing to other methods. And there are a number of rationales explaining this phenomenon, and it's about the thorough submucosal tissue removal of the inflammatory cells, and also reduction of the cells who are responsive to the conditions that led the patient to this problem. So summarizing why so many surgeons perform the powered inferior turbinoplasty. The number of studies, actually it's really vast majority of the publications are related to the clinical efficacy, reveal that it's a safe and reliable surgical technique, and it's performed by the surgeons almost 20 years today. And can be used both in the office-based procedures, in the hospitality setting. And this turbinoplasty allows precise and incremental tissue removal, thereby preventing many of the complications. And because it's critical, we don't want to compromise the mucosa. This is a mucosa-sparing technique, and the mucociliary flow patterns are not disturbed. So all the functions, protection, filtration, and humidification processes continue. And we have number of studies, long-term studies, prospective, cohort, randomized studies confirm that this clinical effectiveness remains high for a long time. So thank you very much.
Thank you very much indeed. Can we ask how much your treatment costs?
That very much depends on the country, and because this is the procedure. In Poland, it's a tricky situation for me to say with the numbers.
Yeah.
And but in the private setting,
yeah,
for example, this procedure costs itself, which is not combined to other procedures, and we convert it into 300 euros.
Okay. So 300 euros, 10 years down the line, completely asymptomatic. One other question before I throw this open. How do you know that it's not the vibration that's causing the benefit, having seen presentation 1? Your machine is vibrating as you take out the tissue underneath the turbinate. So it may be having the same effect as the vibrating balloon.
Well, actually, this blade removes the tissue. And because when the blade is inserted into the inferior turbinate, it sucks, it removes the tissue.
Yeah, but
and flushes.
Yeah.
Not only vibrating.
You don't know, actually. Okay. All right, I think first of all, I would like to throw it open to the surgeons here. Should we start with Wytske? Can we have comments on both techniques from you?
Yes. Of course, there are many ways to do a turbinoplasty. All the surgeons know that, from cold steel, scissors, burning, powered instrumentation. I've never seen, although we all think that keeping mucosa intact as much as possible, that the final results make any difference. Whatever you do, the result is the same. So that would be my question. Is it worthwhile to do it powered if you could also do it with something which is reusable and free, or almost free? So maybe Agnieszka wants to...
There are a number of studies comparing the microdebrider-assisted turbinoplasty or radiofrequency coagulations, whatever. The major difference is that all the other technique that use the thermal effect, the effect drops after 6 months. So with the powered, it's a longer lasting. That's the difference. So then you have to come back. But I would like to stress one thing, that the powered turbinoplasty doesn't address the cause of the problem. No. It just removes the tissues, which is too big, too much. It's just a volumetric reduction.
And it only removes mucosa and not bone.
And yes, and then doesn't affect the. You don't have this fibrotic reaction of the mucosal lining, etc., etc. So, but if the patient, as we had a discussion, has still the allergic rhinitis and is not treated, it's just a part of the procedure. But this is the most effective, and really, this is now the thousands of patients treated this way. And the studies that are published for a number of years are really on a large group, and they are prospective studies.
Wytske, how many inferior turbinate procedures will you carry out in a year, roughly?
5.
Emmanuel?
Very recently, 4 years ago, we've published our data in regards with turbinoplasty in American Journal of Rhinology, with approximately 2,000 turbinoplasties, comparing the CO2 laser in 90s mostly, radiofrequency plus the submucosal cauterization. All the times, radiofrequency and the cauterization submucosally with the CO2 laser over the mucosa. Long-term results, more than 2,000 patients. In all cases, the results were similar, the long-term results, with a success rate more than 90%. I cannot recall the exact numbers right now, but the manuscripts, this manuscript is available in PubMed, so we can retrieve it.
What is long-term?
I think it was 2 years. 2 years. I have experience with the Medtronic powered turbinoplasty, approximately 20 cases. My problem with that was the cost in our country, in Greece. I mean, we can, even though it removes tissue, on the and this is the major difference with all the other techniques, that they are dealing with the thermal effect, actually working with the shrinkage of the turbinate. That was my only issue with this technique. Plus, it takes more time. Perhaps long term it is better. I'm not aware of the comparative techniques. I have no experience with the suggested first technique, but listening to the 5-minute presentation, to me came the idea of applying it to septoplasties additionally, because I have a trend to do cauterization of the turbinates in all septoplasty cases, and I think Peter Hellings does the same, maybe. Not really? Okay. Sorry. And this is my approach. This is what I'm thinking of, and I guess that you do both sides, right? Yes. Both sides. So it is 20 minutes. Yeah, but you. No, I know the other.
Yeah.
So it is 20 minutes.
Total 20 minutes, yeah, 10 plus 10.
Thank you, Emmanuel. How many do you do in a year, procedures? Inferior turbinate, yes.
100.
Okay. Klaus, let's hear your experience.
I've worked with the Medtronic system. You have to follow some tricks, like don't break your turbinate before you want to get in there. That's very clear, number one. That's one time you learn that. I found it very good because you can be precise in what you do. You move underneath the mucosa as much as you can, but you cannot totally exclude that there is at a certain moment a little hole somewhere. But you can use the same shaver also for the end of the turbinate to shave that, actually, just so you don't need another shaver to doing that. For us, having the instruments available, it's about 80–90% per blade for both sides, so it's not a big cost. Do I do it frequently? I do rather on the turbinate side than on the septum side. Something because the turbinate is much more important. Specifically, if you look at the posterior end, I mean, that makes 80 or 90% of the airway resistance of the whole nasal cavity. So I would rather go for turbinate surgery unless the septum is really clearly deviated, and then of course you go for the septum. I have no idea about the other technique. I have to say it's not immediately convincing for me, to be very frank. And I would like to have a clear idea how that should work and how it, if I understand 2 times 10 minutes, it's not, you have to repeat that after a month or so, you said. And then it's good for 6 months. I would like to understand how that works before I'm not convinced, to be clear.
And how many in a year? Turbinate procedures, roughly?
It's always in combination with other things. I don't do that alone, but in combination with others, maybe 25, 30.
Okay. Peter?
Well, first of all, the turbinoplasty is something that we, or a technique that we associate with other techniques like septum correction, rhinoplasty, and sometimes even in fist surgery or in patients with uncontrolled rhinitis. Having said that, this sums up to more than 100–120 per year. But I think what is good here is to stress the fact that we are moving toward patient-friendly solutions here. The elder techniques through which we cut part of the inferior turbinates are now abandoned, and we hear 2 novel techniques here that allow us to apply techniques that are more patient-friendly. The kinetic oscillation technique may be done in an outpatient clinic, and submucosal turbinate reduction is actually not associated with perioperative or postoperative bleeding. So actually, these 2 benefits for the patient should be highlighted. I do agree with Claus that it would be good to understand better the mechanism of the oscillation techniques, and we can already brainstorm about some studies that would that would allow us to understand better the therapeutic efficiency. But I have personally a significant degree of experience with the power turbinate blades, which actually work very well, and the patients are very satisfied without post-operative bleeding or complications or crusting or any other things that may bother them in the post-operative phase. But once again, I would like to stress that I'm happy to see these evolutions, and I hope the patients also express their willingness to support any initiative that is actually leading to a reduced burden in association with nasal surgery.
Talking about patient-friendly techniques reminds me of Ian Mackay's story. Ian Mackay tells that he used to do inferior turbinate diathermy in outpatients with local anaesthetic, in the chair. And then he'd get the patient back about 2 weeks later, and he says, "Now, are you better, or shall I do it again?" The patient, "I'm better, I'm better." So let's hear the patient's view, please. What do you think about these two techniques? Would you be willing to have either of them?
I think this third technique seems a little bit more friendly for patient because you don't see any blood, but of course I don't know what will be the results. In any case, I was very satisfied with the results that Peter gave me after the surgery, and in fact it was not that hard that much, except the cleaning, the suction and cleaning after surgery. That was hard.
But what kind of surgery did you have?
I had Peter took away nasal polyps, and also a correction of the septum, I think.
Okay, yeah. How painful would you say the nasal surgery was, during, after, out of 10? Give it a score out of 10.
4.
Okay, 4. That's not bad. Thijs, do you want to comment, Thijs?
Yeah, I had about 8 surgeries in my nose, so I think I had them all. Although the septum correction you didn't do, so that was before that. Surgery in your nose is awful.
Thank you very much.
That's what all my patients tell me.
That's your physician.
Yeah.
That's right, that's why they see me.
I have 2 lovely doctors who take very good care of me, but my pulmonologist is much more fun to go there than to my ENT. It's on the other hand, the last years, my ENT is now always okay, so I'm feeling better. Surgery itself, no problem, I would say. It's although the first time I had the surgery, I said, well, never again. It's because the removal of the bandage is the feeling that they pull your brains out of your head. It's that was in the beginning. It's, in Professor Fokkens' department, I had a much better thing than that. They use easier stuff, so it was easier. If I look at both techniques, it's everything but avoid bleeding, I would say fine. That's from patient point of view, I think that would be enthusiastic. Everything putting in your nose is not fun. So I have no clue how the feeling is. Putting such a balloon, is it like putting a scope in your nose? Is it the same feeling?
You can try it out. Sorry, we have plenty of doctors that can do it.
But that's a point. And the Medtronic technique, I have no clue. And I would ask what she thinks. So it's the best. But if it's the only thing I see, it is also on local anesthesia. Sounds horrible to me. It's because if they digging in my nose, I better be not aware of that. But that's my personal point of view.
Well, my limited experience with the chordate is that patients tolerate that very, very well. It's I think the same sort of discomfort as a nasal endoscopy.
Okay. That's
very doable.
Yeah, that would be yeah.
Thank you very much. I think there are 1 or 2 very important points to be made here. And one of them is that before doing anything to a patient's inferior turbinates, you need to know that that is the part of the nose that is actually bothering them. And there's no point in just operating on any old patient with nasal obstruction. because the nasal obstruction could be due to a dry nose, which is perfectly patent. It could be due to obstruction at the osteomeatal complex level, which requires completely different form of treatment. So I think the objective measurements need to be done. Preferably, you need to do acoustic rhinometry, but that will splint the turbinates to an extent. So you also need to do nasal inspiratory peak flow, so that you get some idea of dynamic movement in the nose. You need to make sure the patient is not actually suffering from alar collapse, which Peter shows us very graphically. And you need to make sure that those turbinates have not responded to adequate medical therapy, which to me would include oral corticosteroids, which are magic at spiriting away inflammation if it's eosinophilic. So I think the number of patients requiring turbinate surgery is actually remarkably small once you've done all of that. And the other point, I noticed your last slide showed a rather, not a completely normal mucosa on the left, and actually an what I would call an over-patent nose. And you don't want a nose that's a tunnel, because it dries out and feels blocked and you get crusting. You want a nose that is actually a slit that's nicely moistened with proper mucociliary clearance. So I think that's another thing to bear in mind before you do any operating procedure on the turbinates. Are there any other comments that people would like to make?
Yeah, I would like to slip in sort of a little bit of a notion that we're talking about two different patient groups here, I think.
Yeah.
We are targeting the common difficulty to breathe, non-allergic rhinitis. And I think there was a quite nice position paper put out earlier this year that stated it's about 200 million people in the world. And it might be, we believe that. That is very different from the numbers of surgical treatments you all add up to here. So we're talking about different indications, I think. What we try to position this technology is as quite low level but easily available treatment to get out of sprays and avoid surgery. But if you need surgery, you need to go and have surgery. That's our statement, basically. So I think that we are discussing a little bit of apple and pears here.
Okay.
We discussed pathomechanism, but what is the evidence? I mean, can you show data where you followed is there a sham procedure you can do to do it on the other side?
This data I showed the graph of here is plus the number of, I don't know if it can because we're on a different different PowerPoint. But yeah, there are several studies. The last one was about 170, I think, patients or so. And that's where this slide comes from. Right there. Okay, it was there. And this was published in 2016 by Ian Hagen et al. In Sweden. The placebo treatment there is a sort of sham treatment, which we now have validated to a much higher level of perfection, because it is very difficult to sham treat this. But we have now validated this in the next study that in the works, basically. So we are driven by data, and we base ourselves right now on this study plus a number of others, including studies for migraine that also show indications of where this mechanism actually resides.
I'm just curious, but how do you do the placebo?
By, and again, it's tricky, but it's a filled balloon, and there is a sensation of a machine working but not actually working.
The same patient, the same patient. So it's one side, the other side.
Well, there is no crossover in this, so these are they are randomized in each group, the patient in total. So they don't know the difference.
What is striking to me, and most likely also to Professor Wytske Fokkens, is the fact that these patients seem to be symptom-free or having reduced symptom severity for 6 months, which corresponds to some extent to to another type of treatment that we sometimes apply, a non-surgical treatment for this type of patients, where also the interval of being symptom-free is about 6 to 9 months. So it may well be that you play on these same pathophysiomechanisms, but this needs to be explored.
Likely, yes.
Can I make two comments to your questions? One related to the image that was presented here. As I said, it was 7 days after the surgery. And the beauty of this technique is that it doesn't compromise the function of the mucosa. So the nasal cycle comes back to the normal action and other functions of the nasal lining. And the second thing, to the Emmanuel's comment, we on purpose selected the publications when the long-term effect was defined as a 3 and more years. Because as you said, putting anything to the nose, this is not the nicest thing in the world. So we want to do this thing once a time and make the patient happy. Does that make sense to you?
Yeah, absolutely. But well, if you feel awful, you go for it. So
yeah, exactly.
Although I don't like it, but
So
if it has to be done, it will be done again.
It's good said, yeah.
Okay, well, I'd like to ask everybody in turn, starting with Peter, for a one-sentence appraisal of this whole session. What's you got from this session, Peter?
Well, for me, both techniques have intrinsic advantages and some disadvantages that need to be discussed and further explored, but I'm fully convinced that both techniques are actually meeting the needs of the surgeon as well as the patient in going into patient-friendly solutions for a turbinate problem.
Claus?
Medtronic technique, I know, I have done, I know. You can actually see quite well immediately after you have done it or during you do it, how much you do it and how much you remove. So that's the good part of it. The other technique, I have no experience, I have to say, but I would really expect you to come with good evidence. And if I understand that right, it's 1 out of 12 points on this scale, and I don't know the scale. Is that a very marginal effect, or is that
Significant effect.
Yeah, significant is
And
something different from clinically.
Yeah. Of course, it is clinically relevant, and the report in the clinical situation is that I am feeling, like you said in the other session, I have a new life, basically.
Okay. What would you think?
I think the first method likes more friendly for patients, and I don't know if this can be done on the total anesthesia or local. I don't know if this is possible.
Do you mean the first?
Yes.
There is no anesthesia whatsoever? No.
Okay. Then it seems to be fine.
I don't think we can compare these two methods because we're talking about two different things. But I agree with Klaus Bachert that we need definitely more data in regards with the first method. And it is a very, it seems to me that it is a very patient-friendly method. And perhaps if you compare it with other interventions to the nose, the other interventions may have a nocebo effect in the study if you compare it with this balloon.
Well, we're very aware of the possibilities of turbinoplasty, and I think that's a proven method, although I don't, in my population, have a lot of need to do it, but that can be very much patient selection. And I'm intrigued by the chordate method, but I fully agree with Claus and others that we need more evidence before we can cheer. But and there are two parts of the evidence. One is, and that's probably the most important, is does it really work? But two is how does it work? And both are really interesting. And well, I'm sure will find out in the coming years.
Yeah, well, I think let's assume they both work, because otherwise it makes no sense to discuss it. So that's my assumption, and then I think the chordate makes it very clear. It's between surgery and the other treatment. I can imagine that, and I know a couple of patients who said, never again. This could be then a solution, if it works, for those kind of patients who said, no surgery, but this I can accept. So that's, and on the Medtronic, from my medical technology point of view, sounds very interesting, but I have no clue if it's working or not. It's, that I hear, but it looks great.
Agnieszka, do you want to say anything final about Medtronic?
I want to say two things. One is always, as a surgeon, it's a proper patient selection. When the patient is properly qualified for the surgery, is not responsive for the medical therapy, is symptomatic, has to be treated. And this solution works. We have a number of clinical data. And number two, which is I think very important, like you said, that it has a very good long-term result. Yeah. It's lovely to meet with Wytske Fokkens. I love her, but maybe not in the office.
No. The last 4 years, I'm very happy because the surgery is 4 years ago. It's
a social meeting.
Well, also it's always pleasant.
Yeah, thank you.
Yes, we are at the company are extremely thrilled to continue the journey of putting this availability to a lot larger groups of patients and even also expand on the indications as we go further, because the depth of this treatment, as you have indicated, is yet to be really understood. And I firmly believe that when we do that, there's a lot more around the corner.
Well, I'd like to thank you all very much for your presentations and for taking part in the discussion. I think it's fascinating to see that there are options beyond medicine in rhinitis. Thank you all.
Thank you.